Today, I would like to guide you through a structured and clinically oriented approach to renal ultrasound. As we deliver, the key principle is method, standardized acquisition, anatomical awareness, and integration of morphological and hemodynamic information. Let us begin with anatomy and positioning. The right kidney is typically visualized in the longitudinal plane through a transhepatic window along the anterior axillary line with the patient supine and in deep inspiration. The left kidney may require a more posterior or intercostal approach, sometimes with the patient in lateral decubitus. Both kidneys should always be evaluated in longitudinal and transverse planes. One important physiological feature is respiratory mobility. During deep inspiration, the kidney moves caudally along the psoas muscle by approximately 3 to 7 centimeters. This movement is useful. It improves the acoustic window and helps distinguish fixed retroperitoneal masses from the kidney itself. In normal condition, the renal parenchyma is isoechoic or slightly hypoechoic compared to the liver or spleen. Cortical thickness in adults should measure at least about 1.3 centimeters. The medullary pyramids appear hypoechoic and are arranged between the cortical columns. The renal sinus, on the other hand, is hyperechoic due to the fat, vessels, and collecting system interfaces. A critical quantitative parameter is the cortical-medullary differentiation and, in chronic disease, the pelvoparenchymal index. Reduction of cortical thickness and the loss of cortical-medullary distinction are early indicators of chronic nephropathy. From a dimensional perspective, the normal adult kidney measures approximately 10 to 12 centimeters in longitudinal diameter and 4 to 6 centimeters transversely. A symmetry greater than 2 centimeters between the two kidneys should prompt further investigation. Let us now consider anatomical variants. Hypertrophic columns of Bertin, dromedary pumps, and persistent fetal lobulation may simulate focal lesions. Recognizing their echogenicity identical to normal cortex and their continuity with surrounding parenchyma avoids misinterpretation. A horseshoe kidney may present as a paravertebral parenchymal bridge and should not be confused with the retroperitoneal masses. Renal cysts are extremely common, especially with advancing age. A simple cyst is anechoic, round or oval, with thin regular walls and posterior acoustic enhancement. This feature allows confident benign diagnosis. However, when internal echoes, septation, or mural nodules are present, further evaluation is required. It is also essential to differentiate simple cysts from autosomal dominant polycystic kidney disease, in which multiple cysts progressively compress and thin the renal parenchyma, potentially leading to renal failure. Moving to degenerative changes, age-related cortical thinning is physiological to a degree. More pronounced atrophy may follow chronic inflammation, severe renal artery stenosis, or embolic infarction. In advanced stages, the kidney becomes small, hyperechoic, and poorly differentiated. In a unilateral small kidney, comparison with the contralateral side and Doppler evaluation of perfusion are essential to distinguish congenital hypoplasia from acquired atrophy. In inflammatory processes such as nephritis, ultrasound findings can be subtle. The kidney may appear enlarged and hypoechoic in acute stages due to edema, with blurred cortical-medullary differentiation. However, increased echogenicity alone is not specific and cannot determine etiology. Here, Doppler becomes valuable. The resistive index can provide indirect information on parenchymal perfusion and may support monitoring during therapy or in transplanted kidneys. And now, let's address urinary obstruction. In normal condition, the collecting system is not dilated. In early obstruction, we observe dilation of the renal pelvis. With the progression, calyces become dilated, and in advanced stages, the parenchyma thins due to compression, culminating in hydronephrosis. Chronic bilateral obstruction may lead to severe functional impairment requiring dialysis. Differential diagnosis is important. An extra-renal pelvis or prominent hilar vessels may mimic mild dilation. In doubtful cases, color Doppler helps differentiate vascular structures showing flow from static urine, which remains anechoic and avascular. Renal calculi present another diagnostic challenge. They appear as hyperechoic foci, often with posterior acoustic shadowing. However, stones located within a non-dilated hyperechoic sinus can be difficult to detect. Careful scanning and identification of acoustic shadowing are essential. When stones migrate into the ureter, they may cause obstructive uropathy. Ultrasound is highly effective in detecting secondary signs such as anhydronephrosis, even when the stone itself is not directly visualized. Renal infarction, typically embolic in origin, appear as wedge-shaped cortical defects following vascular territories. In chronic stages, they evolve into triangular hyperechoic scars and must not be mistaken for tumors. And finally, we must consider renal and adrenal tumors. Small renal cells carcinomas may initially be isoechoic and subtle. As they enlarge, they become heterogeneous, distort the renal contour, and may invade the renal vein. Careful assessment of the renal vein and inferior vena cava is therefore mandatory in suspected malignancy. Among benign solid lesions, angiomyolipoma often appears hyperechoic due to its fat component, but larger lesions may become heterogeneous and less specific. Adrenal lesions are often incidental findings. While small adenomas may be difficult to detect, larger masses require characterization and, in uncertain cases, further imaging with CT or MRI. Ultrasound also plays a role in identifying adrenal metastases, which may appear as hypoechoic masses superior to the kidney. So, in conclusion, renal ultrasound is not limited to morphology, it integrates anatomy, function, vascular assessment, and dynamic response to obstruction or inflammation. A structured approach supported by Doppler evaluation and careful differential diagnosis enables high diagnostic accuracy and reinforces the value of ultrasound as a first line imaging modality in nephrological and urological practice. Thank you for watching.